introduce the panel. You know everybody up here, but we'll go through them quickly. Former Senator Majority Leader Tom Daschle, who's instructed me that here in Aspen, his name is Tom. I'm used to shouting, Senator Daschle, Senator Daschle. I told him I've been practicing since last year. Former Representative Mickey Edwards of Oklahoma, who's now affiliated with the Aspen Institute. Former Secretary of HHS, Kathleen Sebelius, who basically brought us the ACA. Former Secretary of HHS, Louis Sullivan, and Governor Steve Beshear, who was the only Southern governor to implement the ACA and who covered about 500,000 people in a state where there were really intense healthcare needs. We don't want to spend the entire, if you looked at the title of this program, we're supposed to talk about a million things. So I told somebody it was like everything you want to know about healthcare and you want me to ask. So we will talk about the Affordable Care Act because it's such a huge part of the landscape, and 2016 will be a pivotal year, of course. So we're going to talk about that for a while, and then we're going to open it up and talk about a host of other issues, domestic and global, on healthcare, and then we will have some time for the audience, but I'll tell you it's really hard for us up here to see the audience, but we'll work on that. Let's just start, we could just go down the line. Something, we all know that this election will, as the last two elections also, will determine whether the Affordable Care Act survives more or less intact, or whether, none of us know what Donald Trump would do, but he wouldn't leave it alone, and the Senate Republicans have a roadmap, maybe not for repealing, but for undoing a lot of it. It's covering 20 million people. It has some problems that need to be fixed. Look ahead, what do we need to grapple with? You want to start, Senator Daschle? Tom? 20.
Well, Joanne, I think that we made a lot of progress in terms of new protections in the country over the last 5 years. Millions and millions of Americans have protections that they never had before. The confidence that will never drop, their insurance will never be dropped, that they have access regardless of pre-existing condition, that there's parity between men and women, that young people can sign up. And I think those are such powerful protections that I really can't imagine, regardless of who gets elected president, regardless of who holds the majority, that we're going to lose those protections. I also think with 20 million people now insured for the first time, that it's going to be awfully hard to roll it back. Others on the panel are experienced with regard to the implications of that, but it just seems to me that we've made progress that will be very, very difficult now to roll back. There are huge differences philosophically about the marketplace, but the bottom line is that I think this historic moment is one that we can build on, and I think we will.
How do you have to build on it next year? One thing that you want to see happen?
Well, I think the most important thing as we look to the future is dealing with the other two aspects of the Affordable Care Act that beyond coverage, and that is price and how we pay for health care and quality and how we improve it. I think those two things are going to be the focus of a lot of really bipartisan effort as we look to the future. There's a real opportunity there, and I think we're off to a start. We've got a lot more work to do.
Mickey, you served in government for a long time, a different era. You left in the mid-90s, is that right?
Something like that.
Yeah. Just around the time
Abe Lincoln and I served together, and we had a hell of a good time together.
You're a Republican. You're a Republican who doesn't agree with everything that people currently running the House are doing. This is a big, complicated law. Yeah. It's got some problems. What comes to mind for 2016?
Well, basically, I agree with what Tom said. First of all, there's a fairly good chance, I think, that the next president will be a Democrat. And while most of the power of the federal government actually is in Congress, not the executive branch, but the president has one really great power, and that's the veto power. So even if Republicans kept both houses of Congress, if Hillary's president, there's not much change that's going to happen. In addition to which, the Republicans have a good chance of losing the Senate because they have so many more seats to defend this year than the Democrats do. But Tom's right. There's not going to be a big rollback no matter what happens. For example, and you're not going to get any help from the public because Gallup just did a poll. The majority of Americans want a single-payer plan, and the majority of Americans just want ACA repealed. So it depends on what argument they hear last. But the fact is that in the plan that the Republicans just rolled out, they've already accepted a lot of the things that were in the ACA. That they've accepted the idea, at least if you're continuing to have the continuous coverage with whoever you had it with before, you're going to be able to get covered without regard to pre-existing condition. Young people are going to be able to keep, on their parents' insurance. So I think to some extent, those who were really, really against more government in healthcare have already lost the battle. And they're framing now their new reforms, their new approach, built a lot on the ACA with tweaks here and there.
How do you get past, though, this? I mean, there are things that have to be addressed, and you have a Republican Congress that has voted, depending on who you ask, 54, 58, 62 time, whatever, to either repeal it or take part of it away or defund it. We always say that, there have been more repeal votes than there are flavors of Baskin and Robbins. How do you get to a point where this completely dug in can't talk about, in any law you have to make tweaks and fixes. The most non-controversial law in the world, if it's complicated, you have to come back. We fix Medicare every single year for 55 years. What does it take to get unstuck and say, okay, it is here, it is surviving, and we're not going to just have a repeal vote every week. We are going to try to address affordability or address the underserved or address whatever we need to address. What's it going to take? If you're right, and if it is President Hillary Clinton, what is she going to have to tell Mitch McConnell or whoever it is how to move on?
Well, she can't make the mistake that Barack Obama made, which is going in and telling Congress what to do. It doesn't work that way. So what has to happen is that you have to have a lot of reliance on the Congress itself. And one of the things that's different is that John Boehner is gone, Paul Ryan is there. I've got to say something nice about Paul because I just blasted him, for supporting Trump. But Paul Ryan believes, okay, we've listened to the Tea Party. You're 40 out of our 240 or whatever it is members. We heard you. We're going to move forward. We're going to bring things up. We're going to deal with them. He's already started moving in that direction. So I think there's going to be a mood in Congress, especially in the House. I don't know about in the Senate. I don't know anything about Harry Reid. I can't understand him at all. But in terms, sorry. Yeah, and he won't be there anyway. But in terms of the House, I think you're going to see a House that is much more willing to find accommodation and find common ground.
Well, that's a very optimistic approach. Kathleen, you have grappled with Congress. You're free of that now. If you were back in, which I know you don't want to be, and you had to set the agenda for ACA 2.0, where do you start, assuming that Congress was going to let you do something?
Well, I wish Mickey were right. I don't have quite that optimistic view, and it's not just the Affordable Care. I mean, Congress is stuck.
They
can't
fix
build a
Zika,
road.
Zika,
They can't
right.
pass a highway bill. They can't, do Zika funding. They can't. So this is not unique in terms of the Affordable Care Act. But Tom and Mickey have both said the framework about the number of uninsured Americans who now have coverage is historic, lowest uninsured rate ever in this country. I don't think we will back away from that. I think there is huge bipartisan agreement on moving Medicare from fee-for-service to a value-based purchaser, from a passive payer to an active purchaser, and really driving the way healthcare is delivered in a very different way, looking at outcomes, keeping people healthy in the first place, paying providers differently. I think that's all very good, and I don't hear anybody saying, let's roll that back and let's get rid of that. That's a big piece of the Affordable Care Act. There are also pieces like huge new anti-fraud protections for Medicare. I mean, when all this nonsense about repeal, there are so many pieces of this puzzle that have been put together in the last 6 years. I don't know how you repeal it. But I think the House proposal gives you an idea. I mean, the Republicans, once again, put on the table a drastically cut Medicaid program, the federal and state program for lower-income folks, slashing a huge amount out of the budget and really jeopardizing a lot of the care and coverage for poor women, poor children, frail and elderly, nursing home coverage. But they also put, again, the proposal that you would change Medicare from a guaranteed benefit plan to a guaranteed contribution plan and let people shop with their own vouchers. Those are very different ideas. They have nothing to do with the marketplace. They have nothing to do with the pre-existing condition. I think that's where a lot of the debate may be going forward, because those are Paul Ryan's favorite proposals. He made them as budget chair. He made them again the last couple of years. He put them back on the table as part of the House plan, and I think that may be where a lot of the discussion is for the next administration.
Next. You served in a different administration in a different era, and a more bipartisan era. When you look at the amount of bitterness about this, and it has served in a Republican administration, what occurs to you and how do you want to see it move ahead?
Well, I think one of the optimistic things that I see is the fact that Paul Ryan has stated often that he wants the Republicans to be for something rather than being against something. And I think I agree with my colleagues here that the Affordable Care Act is here to stay. I'm sure there'll be tinkering, and there are certainly some things that should be improved with it. But I think that one of the areas that hopefully we could find bipartisan support is really improving health promotion prevention activities. Here you have tremendous evidence now that didn't exist 20 years ago that lifestyle does influence health. If you take personal responsibility for things such as exercise, vaccinations, diet, etc., this has real benefits. I think everyone can agree with that. This is one way to not only improve health, but also to reduce costs. So I think this is one of the things that hopefully Ryan and his Republican colleagues can join with the next administration in pushing this forward. Because I don't see any upside for the continued efforts to try and repeal this. I think it's been going so many times, it's really a broken record. So I would anticipate that the Congress wants to move forward and not continue to go over battles that really haven't changed anything. The other thing I would say is we need to move forward to say, now that we have the expanded insurance, there are a number of other things that we need to do. Manpower is an issue that I'm very much concerned about. You talk with any professional association, we need more doctors, we need more nurses, we need more pharmacists, public health workers. We need to have people who will deliver what the Affordable Care Act is to provide. And this is another way to really address costs, because the system is not used rationally. We need to really educate our citizens to really use clinics, doctors' offices, rather than emergency rooms, where the care is very episodic, it's not as good, much more expensive. So I see an effort to not only push health promotion, disease prevention activities, improving health literacy, but also an effort to educate the public about how to use the system in ways that they will be better off, as well as unnecessary costs will be avoided. So hopefully we'll see something like that happen.
You implemented the Affordable Care Act. You had an exchange that worked. You had outreach. You were smart enough to call it Connect, not Obamacare, in a southern state that really didn't like Obamacare, but it fell in love with Connect. You covered 500,000 people, mostly through Medicaid. It is seen as a tremendous success story by people who wanted to be a success story. You were term limited, and you were succeeded by a Republican who ran on a repeal message. I'm going to undo the Affordable Care Act in the state of Kentucky. As the campaign developed, the message changed a little bit. He went from, I'm going to get rid of Medicaid to I'm going to change it, but it doesn't, his vision, and he's in charge now, he's gotten rid of the state exchange, he's going to use the federal exchange. He's trying to get waivers that would change Medicaid quite a lot for people, make it hard, more with skin in the game. They'd have to pay more. I think he wants work requirements. What does that tell you about, people up here saying, no, it's here to stay, it can't be taken away. In your state, there is an effort to roll back. So what, and you're fighting it. I mean, I think it's sort of your full-time job now. You're, You've set up a group to fight that. But what do we need to pay attention to about the potential for repealing, undermining, making it look very different?
Well, first of all, I agree with my federal colleagues up here that it's here to stay. But what I'm telling you, and they know it, and this whole audience knows it, is that that place up there is broken. It is broken. Nobody sits down and talks to each other. All they do is yell at each other all day long, then go out and raise money so that they can come back the next day and yell at each other some more. And it's crazy. The only reason that Donald Trump has any traction at all is because people are frustrated. People look at Washington, D.C. and say, my God, that's the last place. It's the last place I wanted to go. I had people asking me to run for the Senate. I said, you got to be crazy. You know, I was governor. I was able to get something done. Why do you want to go up there? You know, Kentucky needed the Affordable Care Act more than any other state in the country, in my mind. We had some of the worst health statistics. We were at the bottom of every list that you looked at. And when I became governor in 2007, the recession hit. I had no idea. If you'd have told me I'd be known as the healthcare governor in Kentucky, I would have laughed you out of the room. I mean, I didn't have any money. We weren't going to do anything of any significance. And then along came the Affordable Care Act. And in spite of the fact that Obamacare is a curse word in Kentucky, you're right, we changed the name. I decided this is our one chance. We got to grab this. We did, and the numbers speak for themselves. You know, we took our uninsured rate from over 20% to 7.5% a year and a half. I mean, our uncompensated care rate, which providers were having to deal with, went from 25% to less than 5% in a year and a half. I mean, it works. It works. Now, we got a guy, a Tea Party Republican, who ideologically wants to change it. Now, we've got every study in the world that says it works, it pays for itself, it's sustainable, it's affordable. And he says, I don't believe them, they're all liars. Now, this is Deloitte, this is PricewaterhouseCoopers, you know, all of these international firms. So we're fighting a fight right now, and he's filed for a waiver that has so many things in it that will never be accepted, and we're going to see where we go. But, you know, the action right now is not really at the federal level, it's at the state level. Shame on the Supreme Court for saying that expanded Medicaid wasn't mandatory. But we've got these fights going on out in the states right now, and I'll tell you one thing, though. People like this. Now, in my state, President Obama has a 30% approval rating, but they like this health care. When we threw the switch on this, and Kathleen Sebelius helped us do it, we threw the switch on this, and hundreds of thousands of people came out of the woodwork wanting to find out about this. And my message to them was very simple. I said, look, you don't have to like President Obama. You don't have to like me, because it's not about him or me. It's about you. It's about your family. It's about your kids. So just look at this. Just take a look at it. I think you're going to like what you see. And God, they love it. And so I think overall in the long term, and I think it's the same thing in every other state, people are going to make sure that this stays around. But if you want to know how to change this mess up there, you all have to change it. You got to start throwing these bums out and getting people up there who will work with each other.
Kathleen, when the Supreme Court did in 2012 made Medicaid optional for states, and you were HHS secretary, were you like thinking, okay, all these red states are going to walk away, or did the administration or you think it's free money, we're paying for it all, they're going to stick with us? I mean, the federal government paid 100% of Medicaid expansion. And a few Republican governors made that case. I mean, in Arizona, Brewer said, why should I send my tax dollars to another state? Let's cover my poor people here. She made a fiscally conservative argument as well as a moral argument. What did you think initially? Because we're still, 18, 19 states still haven't expanded.
Well, the day that President Obama signed the law, March of 2010, 27 state attorney generals sued us, saying the law was unconstitutional. So we knew that there was a battle underway. It started the day the law went into effect. the Supreme Court decision, I have to tell you, out of all the speculation about what they might have done, striking down the mandate, denying the taxes, no one ever saw this coming. No one.
Yeah, we had like 43 different stories prepared, not a sentence about that.
And I spent a lot of time, and up until the day I left, working with governors saying, we want to be as flexible as possible. Call it anything you want. If you'd like me to go out and denounce you on the front steps of the lawn, if that would help your legislature, happy to do it. We'll work around, you have a lot of flexibility around premium levels, around other issues, but, we really think this is a very it is the single most generous federal state cost sharing ever passed.
100% is
100% for the first 3 years, and then
Right.
gradually,
Down to 90,
down to 90%. And I think as Steve says and knows very well, the uncompensated care for hospitals. So what you still have going on, unfortunately, in spite of the financial issues, and is still politics playing out. And we have a lot of governors. I would say there are probably 10 governors, 10 Republican governors, who would love to put this into effect. They cannot now get their state legislators to pass the bills. And they are trying. But I think it took 7 years for all the states to finally join the Children's Health Insurance Program. This is only year 3 for enrollment in Medicaid, and you already have 2/3 of the states there. So I really do think it's a matter of time. And, when you ask people, what is it that you don't like about Obamacare, in most Republican states, it's the Obama part of Obamacare. And I'm somewhat optimistic that maybe when this president leaves office and it can be a little less personalized, that it will become more attractive.
Went through that once, right?
No, but it won't ever be her care.
And to add to what Kathleen has said, my state of Georgia would have had 500,000 more citizens covered had expanded Medicaid. Would have brought $2 billion more into the state's budget. I was serving on the board of Grady Hospital, our safety net hospital. Grady runs an annual deficit, though it's managed very well among public hospitals. But our estimate was that our negative budget of losing $10 million a year would have changed to having a positive balance of $75 million. Now, HCA, the other for-profit hospital chains, they are doing very well by this. It's bringing money into the health system and into the economy. So I agree. I think we're going to see a number of governors who have really been resisting this in a number of states. We're going to see, I feel the same way. I pay my tax dollars, I'm in Georgia. I want to see those dollars taking care of people in my state. It is illogical for me to stand by and feel that this doesn't affect me when I have citizens without health insurance. They're not working. That really hurts our economy. So I agree. I think we're going to see a lot of dominoes fall as this progresses.
Joanne, just one point, because Lou is from Georgia. Georgia is losing a lot of their rural hospitals right now.
Oh, yes.
They're closing because they're going bankrupt. Mine are all in the black.
Kansas, right? Yeah.
In Kansas.
Yeah, mine are
As
all
an
in the black
Right.
because that uncompensated care has gone down so much.
Yeah, I mean, that's,
Joanne, I would just say, I think Kathleen deserves enormous credit for another thing that we haven't mentioned yet, and that is the flexibility that the secretaries need to show to accommodate the unique needs and concerns and even ideas that governors have. I think one of the most successful aspects of this is that the Medicaid program in Kentucky is vastly different than the Medicaid program in Maryland or in Oregon. And I think the reason why is because the Affordable Care Act saw the need to give the Secretary enormous flexibility and authority, really, to adapt to those circumstances. So what you see is just an array of different options and workshops, really, that are going to be tested and tried and in some cases will not work, other cases will. But we're learning a lot in this process as we go forward, thanks in part to that flexibility.
One of the things that's most surprising to me as a Republican is that first the argument that was used in Arizona by Jan Brewer, that it's our money, let's keep it here, keep it for our people. The flexibility Tom just talked about. I mean, those are Republican positions. Those are Republican conservative issues. And so the fact that they did not embrace that, I happen to know some Republican governors who are hoping they get a chance, but they can't be too open about it. They get a lot of pushback from people, maybe because it's the name or whatever. But I mean, this was not a left-wing proposal.
On the phone, all of you said, when we talked before, all of you said you didn't want to spend the whole panel on the Affordable Care Act. Actually, if I let you, you would. But let's
I wouldn't.
let's talk about. I mean, not only do we have long-standing problems in this country, you've referred to disparities, lack of prevention, just bad health, the issues you've had there. We have a whole. Every turn down, we have a new one. We didn't last year. We were talking about Ebola. I mean, how many people in the room knew how to pronounce Zika 6 weeks ago? There's the opioids. There's mental health. These things came up in our preliminary call. There's a list here that could keep us for a month. Let's just sort of touch on some of them, talk about what's at stake at 2016, talk about what has to happen next year. And you did mention on the call beforehand, your state is hard, every state is hard hit by opioids. There's no state that is not hit. It is changing the culture of how we think about some of these problems. But talk about, and Congress has passed, the Senate and the House have both passed some legislation. They haven't finalized it. They haven't agreed on the money. It's not, that one probably will move at some point because it looks like it can. What keeps you up at night? What have you seen in your state?
That issue kept me up at night and still keeps me up at night because it's an old issue that is just getting worse. And I will say that the opioid issue is the first issue. In Kentucky, I was a Democratic governor, had a Democratic House and a Republican Senate. But I always like to say that we were probably the last place in the country where democracy still worked because we could get together and do some things. And that was one of the first issues that I was able to get Republicans and Democrats together and agree that we had a horrendous problem. We had pill mills all over the state. We had the pill pipeline to Florida and other places. I mean, it was just a total mess. And so we passed some really tough legislation, but it was a holistic approach that included treatment. It included more beds, but we ran the pill mills out of the state. We made all the providers use the electronic monitoring prescription system so that you stop.
It's a database that you can look for the
Right, you can stop the doctor
right.
shopping. Somebody around that they bought yesterday around the corner, you could catch them. And so, we did that, and boy, it really started having a great effect. But it's like the whack-a-mole game. We knocked that down, and here came heroin, and here came cocaine, and all the other stuff, the illegal drugs.
And the HIV resurgence in some of the states.
And so we passed comprehensive legislation there that, broadened the use of naloxone for first responders so we could save lives. We, of all things in Kentucky, we allow needle exchanges. Wow. I mean, we've really gotten progressive.
Is that under your administration? Or
Yeah. Oh, yeah. And we got needle exchanges, naloxone legislation. We got tougher penalties on traffickers. But, again, it was a holistic approach that really paid a lot of attention to treatment because if we don't start investing there, I mean, you cannot convict your way out of a drug problem. You got to treat people and get them to be productive citizens again, and that's not an easy task to do.
What are you seeing in the communities you're working with in Georgia? How are attitudes changing? What resources are there? What resources are just hopelessly not there?
Well, I think the problem that we have with opioids is really changing our culture. One of the main things is the stigma that has been associated with drug use. I think that's disappearing because everyone knows someone, if they don't have someone in their family, who is affected by this. And we've had enough from our medical colleagues showing that addiction is a disease. It's not a lifestyle, that there are changes in the brain when one becomes addicted that really are real, so that we have to find ways to treat our citizens, to have them come out of the closet so that they will offer themselves for treatment. This, along with expanded mental health services, are needed as well. So I think that this is a crisis that we're going through now. It's remarkable just how bad it is. But I think one of the optimistic things about it is I think people's attitudes are changing, and we will be able to get more funding and more therapeutic approaches and centers for it. So that's the upside. But it'll take some time to get through this.
But how much of it, going back to the Medicaid expansion, I mean, you have recognition, you have a change in how people speak about and think about and want to deal with opioids and heroin. And it's a pretty dramatic change that's happened pretty quickly. I agree with you. What do you have the capacity? I mean, you again, Medicaid didn't expand in Georgia. There would have been more mental health services. There's still waiting lists and problems in the states that did. But how much of a difference? How much would the mental health piece be better off?
No. We need to enhance our infrastructure, and the most important part of the infrastructure are our personnel. We need to have not only physicians, but nurses, physician's assistants, others, counselors, etc. So we need to have these individuals available when they're needed, because if we don't have access to these individuals for treatment and counseling, then the problem is going to linger and fester and continue and get worse. So that's why I say it's important that we have the insurance. There's still more work to be done to expand it, but we also have to work to see that we have the personnel and the right kinds of personnel. We are going through a change in our manpower. Years ago, we talked about doctors, nurses, dentists, etc. But now we are talking about patient navigators, community health workers, pharmacists providing health education for many of our citizens, which is a new role. So we need to see that we have the right kinds of personnel that not only will provide care, but in the long run will reduce costs so that people will receive care when they need it, rather than having a problem linger and they come in later with much more severe condition. So we need to address manpower as a part of this problem.
Well, I'm going to shift a little. Joanna challenged us a bit to think about other challenges, and I'm going to shift to global issues a bit. In 2009, when I came to the department, we were just in the midst of the outbreak of H1N1, which turned out to be, luckily, less dramatic than it could have been. But it was the first pandemic in 70 years. We didn't have a vaccine. We didn't have the infrastructure. We didn't know how to deliver the vaccine. They hadn't gone through these steps. Here we are in 2016, and since then we've had H1N1, we've had Ebola, and now Zika. And I think that it has provoked some really important conversations where Americans hopefully now realize that the only way to deal with diseases over there is deal with them right here, is to help build an infrastructure of identification and tracking and treatment in various parts of the world, but also that diseases don't stop at the borders. You can't build a wall that makes sure that the mosquitoes don't come.
Really big net.
A really big wall, a really big net. I'm sure it would be a
Make
great
the
wall.
mosquitoes
And
pay
charge
for
the
it.
mosquitoes. Charge the mosquitoes, yes. But I think there has been a reluctance
But
to
not
see
the Canadian mosquitoes. They can come in.
that global health was about somebody else. I think finally folks are saying, really, this is about us. The only way to keep Americans safe and secure is really deal with all of these issues. And we don't have any longer, after 9/11, and I know Tom was, I don't know, Mickey, if you were still in the House, I know Tom was in the Senate, where there was an enormous amount of revenue put forward on a multi-year basis to start dealing with bioterrorism threats and be prepared for antiretrovirals and look at areas that may threaten the health and security of Americans. That money's all gone, and there has been an absolute unwillingness of Congress to refund that pipeline, to relook at this issue. So one at a time. I mean, you just saw the House just passed a bill on Zika virus. Most of the money that they passed, they took out of Ebola funding, and they took out of the department's infrastructure, and they're just kicking the can back and forth. It's half of the money that CDC said they needed in the first place, but none of it is new money. None of it will actually help put together this infrastructure, and it's pretty terrifying, because these are diseases that could have lifetime impact on lots of our citizens going forward, and they certainly will have a devastating impact across the globe, and we have to really start stepping up on global health issues.
In 2011, in 2001, rather, after 9/11, and the anthrax was in your office, there was actually a very sort of strategically smart thing that Senator Kennedy did with Senator Frist, in which they did the bioterror bill. It actually, Senator Frist understood a lot of things about I guess here he has to be Bill, but he's not here, it doesn't matter. He understood public health, and he understood sort of the depletion of public health resources in the United States. And he called it a bioterror bill, and Kennedy worked with him, and you worked with him.
$80 billion.
And you were able to do, by calling it bioterror, you were also able to get some county in Montana, in those days it was the fax machine that they needed, that they didn't have, so that they could actually communicate with the CDC, communicate with each other. It sounds like we made some gains, and that we've actually, as we've become more globalized and sort of been hit in the face with how fast disease can travel and new scary ones, are we worse off than we were 15 years ago?
We are worse off, and I think, Joanne, that what triggered all of that, of course, was the real feeling that we were threatened, and because we felt we were threatened, we found enormous bipartisanship. I mean, there were two things that we did in that period that I think were striking. One was we came up with the money, and two, we created the infrastructure to be able to think about how to best spend that money as we prepared for our defense as we went forward. But now, as Kathleen said, the money's dissipated, and really the infrastructure that we had created is virtually gone as well. There is little doubt that at some point in the future, we don't know when, we're going to have another attack. And whether it's natural or man-made, we are going to see the same kinds of threats we faced already, and we're not prepared today. We need to stockpile some of these measures. We need to have the resources necessary. But even more importantly, we need the organizational effort within the government itself to be able to work with the states and to work at the federal level to ensure that we're protected. We don't have that today. I think it's just a crime that the Congress left town without dealing with Zika and finding the funding necessary to address it, because it's a problem that's only going to get worse.
Yeah, the earliest they can fix this now will be mid-July, and that's well into mosquito season in a big chunk of America. I think some of them were surprised. I think some of the Senate may be surprised that it didn't get a little further than it got in the House last night, 3 o'clock in the morning, whenever it was. One or two things before we turn to audience questions. I know there was another issue. Mickey, you want to?
Well, there's a couple. One of the things in terms of what Kathleen was saying, one of the ways that people in other countries were able to deal with some of these crises is through help we gave through our foreign assistance programs. And there is a big push to cut back even more on foreign assistance, which it hasn't been adequate in a long time. That's part of the problem. And let me just mention two other things. One's been mentioned, but at different ends of the age spectrum. One is on mental health. This is a particularly large problem for young people, access to mental health. Not only insurance coverage, but facilities near enough, to be able to do this. And, the other end of the spectrum is dealing with cancer, because the incidence of cancer is increasing. We can take care of it more. There's more survival, but as people get older, the aging population has more cancer, and that's another area where we need to put more funding. So all of the efforts, in Congress about how do you cut spending, there are some areas where we need to be spending a lot more than we are. And that's a couple of them.
That's one of the areas where there has been some bipartisanship, both last year and this year. There's been a big increase in the funding for NIH. I think it's $2 billion they're talking about.
But it's never new money.
No.
It's taking money from someplace else, so that drops dramatically. I mean, it's the worst time in the world to cut back on funding and research because the science
It's really
is so
exciting,
dazzling
right.
and the breakthroughs have been so enormous,
they're
and
real,
the human genome can map precision medical responses, but we are slashing budgets, which makes no sense.
We should probably turn to the audience. Who has the mics? I can't see very well from up here. And please make sure you're giving a question, not a speech, because I'm tougher than I look. I raise teenagers. I'll cut you off.
I have a mic.
Use the mic back there.
Okay. Who? All right.
In the second row.
Oh, I'm sorry.
Stand up. Maybe I'll be able to see you. We're right here. Okay. Can you identify yourself and
Yes,
question?
my name's Larry Gelman. I live in Tucson, Arizona. And my question is related to the election. And I watch a lot of news, and I'm hearing things for the first time tonight, things that I haven't heard before. And I'm wondering what your opinion is of the news media's job and the way they cover the election. Is it going to be possible for any of these real issues to get any kind of traction when it seems as though the media is so fixated on giving surrogates for Trump and Clinton equal time and allowing them to say whatever they want? It seems like we never get down to the real issues. And I was just wondering if anyone had some thoughts about whether that's going to get any better or if it's going to stay the way it is.
Well, I think we're required to start by saying Politico is really good.
I've got 9. I have 9 healthcare reporters, 3 additional ones who are on digital health, and we cover all of this. And we have a free daily newsletter that you can sign up for. We also have a paid one you can sign up for, but there's a free one.
But I do think that's a relevant question. And if Donald Trump becomes president, which is a scary as hell thought, if he becomes president, the news media is complicit in this. Their ability to ignore this, and was it Les Moonves, the head of CBS? We don't know if Trump's good for America, but he's good for CBS. The pursuit of short-term ratings and money by the media has really been disgraceful this year.
It's on now? Okay. The question is addressed to anyone on the panel. We've all read in the last few weeks about a number of insurance companies, Humana, and opting out or raising rates 25, 30% because they underestimated what the cost structure was going to be. It was all, everybody was out there saying, we're going to get all these new people, all these young people, but guess what? We're going to get people who are not so healthy. How can you, what's going to happen?
I think Kathleen
the
can
insurers
answer
have
this
lost
better than
$2.7
any of the
billion.
rest, but
It's real.
I think one of the most important things that got very little attention is how critical the risk corridor mechanisms we built into the law were. I mean, that was our deal with the insurance companies because this was a new model and we really didn't know how to predict just how this was all going to play out. So what we said is we're going to share some of the risk with you. But the Congress has refused to provide the funding that would allow for the kind of risk amelioration that is so critical here. I mean, that's a really big part of it. I think the other thing, when you hear about these rate increases, keep in mind that the average premium is around $104. I mean, that's not too bad when you consider what you're getting in value for coverage. So it may be percentage-wise a lot, but anywhere from $75 to $104 a month is much more of a tolerable premium level than I think a lot of people realize.
The headline is 25 or 30.
It is.
Right.
And so nobody's looking at the real number.
Exactly.
And the real numbers vary from state to state. I mean, there's no question that competition helps drive down rates. And one of the goals of the marketplaces was to get new companies to write individual coverage. 25% of the people who wrote in marketplaces across the country, 25% of the insurers year 1 were brand new. Another 25% came in year 2. United, which frankly has done the most bizarre thing I've seen, where they issue a press release a day based on a state a day. United wasn't in at all in 2014. They came into 3 or 4 states in 2015. They played bigger in 2016, and now they're pulling out. But that has not really changed the overall composition in most states. And there are other insurers who are expanding. But Tom is right. The framework And this is not new to the Affordable Care Act. It's about market risk. For 5 years was supposed to be risk adjusted. So everybody was sort of bidding blind. And we said if you had far more older and sick people in your plan than you got in your plan, we would shift that balance a little bit. And when Congress didn't fund that, you're suddenly on the hook for a brand new vulnerable plan. So they're still fragile, and in some states there isn't enough competition, and that has allowed rates to go up. But by and large, there are lots of new insurers playing, and the rates are still, I think, very acceptable for most of the people who are buying coverage. Competition is where it's at. Yeah.
We ended up in Kentucky for years before the Affordable Care Act. We had 2 companies. That's it. And they kind of had their way because there wasn't enough competition. This last year, we had 7 companies providing these plans all over the state. It was amazing that, we turned around in Kentucky and went from 2 to 7. And like they said, that competition is what, in the long run, is gonna get these rates where they ought to be.
And you'll see just one more anecdote, because you're going to see a lot more about this. The proposals of the big insurance companies to go from 5 big companies to 3, the mergers that are pending are now being looked at by the Justice Department, looked at by the FTC, looked at by state regulators. But part of the issue that is the federal regulatory lens is, will this make health insurance less competitive? Will this be good for the consumer? If you shrink the market by that much, what happens to people at the end of the day?
There?
You've explained the difficulties with medical care in the country, and I understand it. By the same token, the 3 largest items in our federal budget, Social Security, Medicare, Medicaid, and interest on the debt. I'm curious as to how we start to deal with what appears to be continuing increasing costs as our population gets older to pay for medical care for all of us.
Well, I would start. We need to do a number of things to redesign the system, because the system is not used rationally by a number of our citizens. In my state, in Atlanta, we have too many of our citizens who call for the ambulance to go to the emergency room, where there's a $1,500 bill generated, when indeed they have some ache that would have been taken care of for $100 at a local clinic. So, and there are many examples of that. So I agree. I think we all agree that we are spending too much, but we're not spending it in the most rational way. That's why we need to redesign the system. I was talking earlier about manpower issues. We load our health profession students up with debt to get an education. And then when they graduate, we say we want them to go into rural areas and practice primary care, when they're looking at a debt of $150,000 or $200,000. That is something that did not exist 30 years ago. There were scholarships, many ways that students could provide their education. But what we are now doing is generating health professionals who are going out and trying to find ways to reduce that debt. So we have a dysfunctional system. So there are a number of things that we must do if the system is going to be viable. Another is emphasizing health promotion, disease prevention, to prevent illness from occurring in the first place. So there are a number of things that have to be done to address that, but we have to have the will to do it.
Tom, do you want to talk about some of the areas of bipartisanship that has been delivery? We have to explain what delivery system reform is, otherwise they think they're not getting their mail. But some of there has been a bipartisan progress and understanding about that addresses this question.
No, I think there is. Once we get beyond the Affordable Care Act, there's a lot of support, as Kathleen, I think, mentioned earlier, about the need to move away from the volume-driven system we have today. One of the reasons we spend more than anybody else in the world is we have a volume-driven fee-for-service mechanism that rewards more volume and really doesn't bring into the equation the quality that is so critical. We don't have the transparency. I always like to say, I don't like to say it, but we have to admit, healthcare is the only sector of the economy where at the time of purchase, we don't know what it's going to cost or who's going to pay. There is a lot more transparency around sports in America than there is around health, and we've got to change that. And on those kinds of things, there's a bipartisan effort underway now to bring telemedicine into healthcare a lot more effectively. There's some wonderful things we can do with telehealth in home health settings and in all kinds of new settings that just didn't exist before. All of those things, I think, are areas where there is meaningful bipartisan support. The effort towards population health and wellness, something Lewis has mentioned a couple of times now, that bipartisan support for it. We just have to come up with mechanisms to ensure that we take this sense of commitment and consensus and turn it into good public policy.
Well, and there was a lot in the framework of the law that gave, for the first time, some new tools. And I know that, these are not my numbers. These are the Congressional Budget Office and bipartisan economists. Health inflation over the last 5, 6, 7 years has risen at the slowest rate ever recorded in the history of the United States, in public plans and in private plans. Now, everybody feels they're paying too much, and it still is too much. And as Tom said, we still spend almost twice per capita what any country on earth spends on healthcare. And our health results are pretty mediocre. To me, that's one of the real issues. We are not getting a very good bang for our buck. Our citizens live sicker and die younger than most of our global competitors. And that's part of the shift, is how you make Medicare. Medicare spends $1 trillion a year on health services. How you take that $1 trillion and make that a lever to a value-based proposal. And that's really underway. And so whether it's costs coming down on Medicare overall, the per capita Medicaid, there are 11,000 people in this country who turn 65 every week. 11,000 people. So we are going to have costs go up in Medicare just based on numbers of people who are eligible for the program. But per capita costs are as low as they have been in years, and that's really, I think, turning a corner that we just haven't seen.
Do you want to talk a little bit about what governors are doing about Medicaid? Because there's the old, you have the cut benefits, you can cut providers, or you can come up with a new way of paying. And
I'll tell you what we had to do in Kentucky, and nobody thought we could do it. During the recession, we were looking at going under. There wasn't any money. There wasn't any tax money coming in, but the expenses kept going. And unlike the federal government, we've got to balance our budget. I know that's a novel idea, but we have to balance our budget every year. And so the Medicaid program, I was faced with cutting benefits, which I was just determined not to do, or doing something else. And what we did is we took our fee-for-service thing and just wiped it out. We went to managed care. And by that, what I mean is that we brought private companies in, and they answered RFPs, and we basically approved them. People signed up, and the Medicaid program went to them, and instead of paying $50 every time a doctor took your temperature, and so they'd take your temperature 8 times, so 8 times 50, that's fee for service. That's what we're talking about, is that every time somebody does something, they get paid for it, and all you're doing is writing them a check. What we did is say, company, you got 100,000 of our people. We're going to pay you X dollars this year for that person. You got to manage their care. You got to make sure that they do get good health care, but you're not getting any more money. So you get with that hospital. And when somebody goes there for a headache to the emergency room, you're only going to get $15 for giving them some aspirin and telling them to go home, and they've got to go to a doctor down the road tomorrow and figure out what's wrong. You've got to get to a point to where somebody is managing that person and making sure that they get what they need, but it's not always what you want. It's what you need, and that's tough. That's not an easy thing to do. And there's a game, you know, companies will sometimes, because they got to make money. So some of that $100 that I just gave them for a year for that person, they got to make money off of that. So they got to manage that person, but, you know, don't cut too many corners. You can see where you can get into real issues with that. But when we're talking about going to a value-based system, that's what we're saying, is that we want a person to get the health care they need, but you don't pay for every sponge that goes out like we do today.
We have time probably for just one or two more, right here.
Dan Ovadi, I'm an orthopedic surgeon and master's in public health. Let me first address your bit about the risk corridors that Tom talked about. That was exactly the approach that was used when Medicare Part D went through during the Bush administration. There wasn't any complaints from anyone about, you know, paying insurance companies, whatever. If they lost money, they would get reimbursed, and if they made extra money, the government would get money from them. Very much like what we did in the auto bailout. With respect to some of the optimism up here, first of all, I think the fundamental problem, if you drill down on this, is Republicans, and I don't mean to attack you, Mickey, and you may not be like the typical Republican. They
I wrote a book in 2008.
Okay. They fundamentally don't believe that everyone should have health care. That is their fundamental philosophical viewpoint. And they don't believe that everyone is deserving. The deserving should have, the others should not. So unless you change that mindset, all this stuff about you asking for more funding in Georgia for all these people, public health, that ain't going to happen. Kathleen is telling us all they're doing is shifting money around for Zika. They don't want to raise taxes. That's the fundamental problem, that we're not paying taxes in this country. And I could go on this stuff for hours and hours, and I won't bother you with it. But I just don't see this stuff happening. We did a research project last year, and I talked to Bill Aslam in Tennessee. Great guy, loved to have it, worked with all the, the 1115 waivers.
Trying to do Medicaid, his state legislature won't let him,
And he was all for it. It was going to help Tennessee tremendously, and all the rural hospitals were closing down. He couldn't get anything through. And, the country is so goddamn polarized now, with Democrats and Republicans hating each other more than ever. There's absolutely no way that we're going to get compromise on this stuff, I don't think.
Okay, thank you. Right. One more question, and please make it a question. We've got one more. A real question.
Yes.
Bill Williams?
Oh, I'm sorry. Somebody else? I just wanted to the Colorado ballot has a single-payer initiative for this year. What does the panel think about states doing single-payer? I mean, I know they tried it in Vermont and it didn't work. Is that a viable option, or does it have to be kind of a national program or nothing?
Quick answers, and we can then wrap it up.
I don't know enough about the Colorado initiative. I do think when the bill was first put together, the hope was to have a public option, which would have basically been a single-payer option, as one of the choices. I'm a believer that if you can make that a viable plan, that's a good choice for people to have, because we still, while competition works, we are, again, one of the only countries in the world that takes a 12 to 30% layer on the top for administrative costs and paperwork and executive salaries and agents and brokers and whatever else. So, but I just don't know enough about, if you're asking, can the Colorado plan work? I don't know how it's structured, but the public option certainly could have worked, I think.
All right. Anyone else want to say Colorado? If not, we're going to wrap up. Vermont did not manage to do it, and they had a governor trying, and Colorado's a governor who's not for it. So, all right. Thank you all for being here tonight. We did cover a lot of ground. Thank the panel. Right.